Good afternoon and welcome to another webinar presentation.
Great.
Good afternoon, everyone. My name is Drew. As John mentioned, I will be the incoming EMS fellow starting in July. This afternoon, we'll talk to you about the AHA guideline update that was released in 2015 as it pertains to pre-hospital care. So our objectives for this talk this afternoon are to review the key changes and issues as they pertain to the AHA update. Some of the updates, some of the recommendations are going to be pretty straightforward and pretty basic, but I find it's helpful to understand the background and rationale that underlie these recommendations. Primarily, we'll be looking at the role of dispatch in CPR identification and delivery of dispatch CPR, the role of naloxone, the CPR metric guidelines that have been updated in this iteration of the AHA guidelines, as well as changes to medications used during cardiac arrest care. So just to give you a bit of background about how the AHA operates to kind of form their recommendations, AHA base these recommendations on a review process using an international committee of reviewers. They also use the International Liaison Committee for Resuscitation to come up with a selection of topics that they want to review, and then they provide those topics to the international group of reviewers, and this year that numbered 250 reviewers. Once they identify these topics, the reviewers use a standardized approach to make sure there's some sort of internal validity and internal consistency with respect to their review of evidence, and then they come up with some recommendations based on the literature. The purpose of these guidelines essentially is to come up with recommendations for use in practice, and they rank their guidelines from class 1 to class 3 based on how strong the evidence is and based on the benefit that's attributed to each recommendation. Class 1 being the strongest level of recommendation, and class 3 being either of no benefit or of harm. And they word their recommendations most of the time somewhat in vague terminology, and that just has to do with the level of recommendation that they come up with. So you'll often see they say things like, this recommendation may be implemented or could be implemented, and that's just has to do with the evidence and the recommendation.
One of the things we were talking about when we were preparing this talk was the fact that it used to be that every 5 years everything was reviewed thoroughly, and that now it seems to be that out of the last update, in 2010 was the major last revision. The update was 2015, and now they describe it's going to be more of an iterative process when, as new evidence comes out, they'll release new guideline changes. So those big, everything changes every 5 years may actually not be the way things move from the future.
And with this iteration of the recommendations, they've released this big document, almost 300 pages long. They've divided their topics into 15 parts that have to do with various aspects of CPR and cardiovascular care, and they've come up with a total of 315 recommendations throughout all of those parts. And certainly we're not going to talk about all of the recommendations. Not all of them pertain to pre-hospital care, and not all of them are necessarily relevant today.
All of them pertain to different questions they asked, and of the questions they had, if the new questions didn't address anything from the previous guideline, then the 2010 guideline still applies.
Yes, yeah. And as Dr. Luell mentioned previously, the guidelines were released sort of on a 5-year rotation previously. This leads to a bit of redundancy with the recommendations, and sometimes they will have a question that has no new research for it. And so again, going forward, the AHA sort of is aiming to be a bit more dynamic and releasing recommendations as new evidence becomes available. And again, we're going to focus today sort of on dispatcher CPR, bystander CPR, Narcan, and then ACLS and BCLS recommendations. So jumping into sort of the first section of the guideline update that has to do with CPR is the ethical issue kind of category. And so just starting in with the sort of first recommendation we have here is that it has to do with withholding CPR and situations. They essentially recommend that situations where CPR places the rescuer at risk of serious injury or mortal peril are reasonable to withhold CPR. And then obviously signs of irreversible death are also situations in which CPR is reasonable to be withheld.
When's the last time you used the word mortal peril in a sentence?
Yeah.
It's so medieval.
Yeah, only today. Only today. And then they also have a recommendation with respect to extracorporeal CPR. There's insufficient evidence to recommend its routine use, either out of hospital or in hospital, and probably more so out of hospital as well. But they go on to say that it may be considered in situations where it can be rapidly implemented, or when the etiology of the arrest is reversible. And again, this is based on evidence that has to do with in-hospital cardiac arrest, so not really applicable to the out-of-hospital environment. And again, the evidence, even with in-hospital cardiac arrest, is not the greatest.
It seems like this is one of those things over the time that we're going to develop more and more experience with this. More and more evidence will start coming forward, and then we'll see centers which will probably be specialized in this, which speaks to the overall systematic outline we're going to have of our pre-hospital care system, which directs towards cardiac resuscitation centers. Yeah. So this may be something you will see 5 years from now. Will this be an older change that now will be modified in the future?
Yeah, for sure. Moving on, in the ethical issues part, they talk about end-tidal CO2 as a means of sort of prognosticating mortality with cardiac arrest. And their recommendation is that an end-tidal of less than 10 millimeters of mercury immediately after intubation and less than 20 minutes after the initiation of resuscitation is associated with extremely poor chances for return of spontaneous circulation and survival. And this is with endotracheal tubes and not supraglottic devices. However, there's a lot of variability in the evidence, again, with this recommendation, and there's a lot of false positives and false negatives with respect to the detection of end-tidal CO2, so it shouldn't be used in and of itself to decide when to terminate resuscitative efforts.
It's like many things, it's one of those pieces of the puzzle where we've had that we'd like to sort of hang our hat on one nice little guideline that will tell us that this is when to stop, but clearly there's not one thing we can just do.
Yeah. But it can certainly contribute to that decision.
Mm-hmm.
Moving on to the next part that we'll talk about today is systems of care and continuous quality improvement. So the AHA has, which is new in this year, or new in the 2015 update, they've kind of devised this framework that they sort of envision resuscitation occurring within, and this includes factors from a structure and process point of view that then lead to a systems point of view and ultimately a patient quality improvement kind of point of view. They're sort of ideology is that this sort of framework is going to lead to better patient outcomes and better delivery of CPR with cardiac arrest. And as per this framework, they've come up with two new chains of survival, or I guess one new chain of survival. In 2010, there was one chain of survival that had to do with basically pre-hospital delivery of CPR, and that is still present in this iteration. So that's the lower chain of survival you see there, with recognition of arrest and activation of the emergency response, and then CPR, rapid defib, and transport to advanced care. But they have also added an in-hospital chain of survival, which is just a new feature of this iteration of the recommendations. And with respect to this framework of care or systems of care that they envision leading to better outcomes, they've included recommendations that have to do with public access to defibrillation. And they recommend that public access defibrillation programs be implemented in communities with those at risk of out-of-hospital cardiac arrest with a Class 1 recommendation. So this is sort of the strongest recommendation that they can give. Certainly, any community has people at risk of out-of-hospital cardiac arrest. So this is a pretty sweeping statement.
Yeah, I was trying to think what those communities would be that there's no risk of out-of-hospital cardiac arrest. No, everyone here lives forever.
Yeah, they don't exist. Yeah.
It's the Highlander community.
Yeah. Everywhere needs public access defibs because of this recommendation. But there is evidence certainly that public access defibrillators are associated with improved mortality and at least improved admission to hospital. So that is the rationale for that recommendation.
One of the things, if you look at the studies, looking at public access defibrillation, though, too, is it's never just a box in the wall. It's also, it comes with usually some training for either the people that work in that office or work at that arena. There's someone that actually is empowered to know where it is, know how to use it, and also should come with some quality improvement and quality assurance to make sure that the pads are not out of date. And many of our communities who have partnered with the paramedic system with this have actually ensured that that happens as part of their normal maintenance, which is very helpful.
Yeah. And so the next recommendation has to do with dispatch and dispatch-guided CPR. So the recommendation this year is that dispatchers determine if a patient is unconscious with abnormal breathing in a multitude of clinical scenarios. And then essentially the gist of it is that if the patient is unconscious with abnormal breathing and the dispatcher can recognize this, then it's reasonable for them to assume that the patient is in cardiac arrest, and we'll see later that it's reasonable for them to sort of guide bystander CPR based on this assessment.
Absolutely. I mean, we used to, the challenge here and the key is the abnormal breathing, and that they used to say, as the person responding to you, no, are they breathing? If they said yes, then people would not think go on to CPR because they felt to be breathing. But clearly we all know, watching someone arrest, they still have those sort of brainstem breaths, those big sort of guppy breaths they have, and that may delay someone from CPR, and nothing wakes someone up like CPR. So if they're not truly arrested, well, then we'll know very quickly.
Yeah, so they're kind of hedging here, the benefit being that the CPR is going to, at the very least, benefit them, and if not, it'll wake them up.
Absolutely.
The evidence for this recommendation was a bit funny. There's really no evidence to suggest that dispatcher-guided CPR, when they instruct a bystander to perform CPR, that it decreases time to initiate CPR. And there's also really no evidence that it improves favorable neurologic outcome or discharge in any independent study, but a meta-analysis did show that there was a bit of a survival benefit to dispatcher-guided CPR. And so that's sort of the background for this recommendation. And then along the same line, sort of what Dr. Llewellyn alluded to earlier, where the public access defibrillators are sort of integrated with a quality improvement kind of side of things. In these areas where there is public access defibrillation, there is a recommendation from the AHA that sort of involves social media. So people who are trained in delivery of CPR or basic life support are sort of almost on call in a way, and whenever there's either a public access defibrillator that's used or a call to dispatch, they can send out a message, either a text or a call, to people who are trained within a certain range, like sort of half a kilometer to a kilometer of the location of the arrest, to go and provide CPR. And again, this is a new recommendation that's unique to the 2015 update.
And we're seeing more and more of that. If you're those of us that are active on social media, I'm not really active in terms of tweeting, but I'm certainly active in terms of following different information sources. And certainly you'll see lots of different advocacy groups forwarding this and actually promote different paramedic services in the U.S. that are now joining some of these social media sites. We have now, our whole community has gone onto this site, and this is what we're doing. And I know there's lots of discussions happening provincially about bringing this to Ontario as well. So this is probably what we're going to see evolve over time. Absolutely.
And in keeping with the sort of systems of care theme of this part in particular, this recommendation just has to do with regionalized cardiac care and cardiac resuscitation centers. And their recommendation is that sort of a region-by-region approach to cardiac arrest could include the use of cardiac resuscitation centers. And this recommendation is based on the fact that there is some evidence to show improved outcomes, improved survival, improved neurologically intact survival with involvement of specialized cardiac care centers.
If we think of all the major changes that have happened in paramedic systems over the last few years, to be honest, I think that the system of care model that's used now in trauma for trauma centers and trauma networks, and we have specific criteria for that, as well as we have stroke networks and stroke centers and stroke units that are associated with improved outcomes. So this is a natural evolution of that we have. Not only do we have STEMI bypass, but now we're having specialized cardiac, specialized resuscitation centers where that's maybe you blend in your ECPR, and other sort of forms. And I really think, and one of the things I'm most proud about of our paramedic partners is that this is sort of what we see the impact to care is now they're so now embedded directly into the actual healthcare system. It's not just you bring them to the emerge or to the closest appropriate facility. You bring them to where you, given your diagnostic skills and therapeutic skills, bring them to where there's best benefit. And that may mean in some situations you're in the ambulance longer, but that's fine because you get that benefit you have with that specialized paramedic bringing to a specialized center far exceeds maybe just what we used to think was important, like getting the IV in 2 minutes faster. So it's really remarkable. So that's a great benefit we're seeing.
We'll touch on this a little bit later as well in the talk. And again, we talked about this a little bit earlier. Bystanders can often misinterpret the sort of pre-terminal agonal gasps that patients have when they do have cardiac arrest. So it's important that dispatch is able to sort of parse that out and determine who is truly arrested and who hasn't. Again, at the beginning of the talk, we talked about how some of the recommendations within this big, huge document are a bit redundant. So this is one of the examples of that. But again, if the dispatcher determines that the patient is in cardiac arrest, they basically just look at whether or not the patient's unresponsive, or if they have these agonal pre-terminal gasps that the bystander might relay to them. Pulse checks, so a similar recommendation to the 2010 guidelines. Healthcare providers should check for a pulse prior to their CPR, limiting that time to less than 10 seconds just to delay the initiation of CPR.
It's interesting. The wording of this is so important. So the other one is, for instance, the lay public, and they divide it between lay responders versus healthcare responders. And this is the healthcare provider. So it's the healthcare provider that's supposed to do the pulse check and less than 10 seconds. As we know from the work from Dr. Cheskis with regard to perishock pause as well, it's very clear that these pulse checks can be very limiting.
And they do suggest that lay people or non-healthcare providers should not do a pulse check and should just either start CPR, or if the patient isn't in cardiac arrest, obviously not start CPR.
It's a great way to wake up from a nap, eh?
This recommendation seems fairly straightforward. It's reasonable for healthcare providers to provide CPR and ventilation for all patients in cardiac arrest from either a cardiac or non-cardiac cause. There was a study released not too long ago looking at continuous CPR versus interrupted CPR or standard CPR. The continuous CPR group received compressions at a rate of 100 per minute, and the sort of control or standard CPR group got the usual 30-to-2 ratio of compressions to ventilations. And the rationale was that the interruptions that are present in the standard group, or the group that's getting 30 compressions to 2 ventilations, might be detrimental. But in comparing these two groups, so comparing continuous chest compressions versus the 30-to-2 group, there was really no difference in outcome in terms of survival from to hospital discharge. And the study that did this did have a couple of issues. One is that they didn't really control for the percentage of shockable rhythms. So the group that got the standard CPR 30 compressions to 2 ventilations had a higher incidence of VF and VT. But along with that, the study's a bit interesting in that maybe we're underappreciating the value in good ventilations. So maybe the group who got 100 compressions per minute, who got sort of asynchronous ventilations. Maybe those ventilations weren't effective. Maybe there was the intrathoracic pressure was too high and they didn't get a good good ventilation. Maybe that's why they had sort of a non-significant study. And because of that, the recommendation is that as per previous, patients should get both compressions and ventilations at a 30-to-2 ratio instead of continuous compressions. And we'll see there's a bit of a caveat to this in the next 1 or 2 slides, but that is the recommendation currently.
So this is often typical of research. You go out to answer one question, and 5 more questions develop out of that one research project. So, very often find that with this type of research that you don't always get the answer you think you're going to get, but more so then you start hypothesizing for other studies. Okay, why was there no difference? Is there something else we should be looking at?
Or like we see with the ALPS trial, for instance, what you'll see is people actually are concluding from that their own, finding theories which support their own personal biases to sort of promote why we found that particular finding. So it's really unique how sometimes the finding can then be interpreted 3 different ways, even though the finding itself is fairly concrete. It's how it's interpreted is very subtle.
And this is sort of what I alluded to in the last slide, and it has to do with delayed ventilation. So for witnessed out-of-hospital cardiac arrest with the VF or VT, it may be reasonable to delay ventilation until they've had 3 cycles of 200 chest compressions with intermittent defibrillations. This isn't avoiding oxygenation, so they are providing passive oxygenation with either nasal prongs or just a face mask, but they're not doing anything more invasive than that to provide positive pressure. And there is some suggestion that this might be a reasonable approach, and it's certainly in practice in some EMS systems where they are using a bundle of 3 cycles of 200 compressions with passive oxygenation and intermittent shocks for only VF and VT and for only witnessed arrest.
It seems we revisit this every 5 to 10 years. I mean, there's a PRIME study, then there's this, and then there's CCC, and it may all boil down to the fact that from a patient perspective, what you're getting is a CPR, time on chest fraction, that is so subtly different between 2, and your outcome is so dismally poor for all cardiac arrest survivors that you're trying to basically measure a very subtle change in the actual intervention to an overwhelmingly high mortality rate. You just may not see it come across, and that's why it seems that there's so much ambiguity with all the different overlapping recommendations. So CPR is good.
Yes, long and short of it,
CPR and electricity.
That's right.
Things that have been tried, tested, and true throughout these studies.
Yes, exactly.
Moving on to the naloxone, a lot of talk in this iteration of the guidelines has to do with naloxone. And there is a bit of redundancy as well with the recommendations as they pertain to naloxone. But within this sort of section of the guidelines, they recommend that for patients with known or suspected opioid overdose with a pulse but abnormal breathing or agonal gasps, it's reasonable, in addition to standard care, for trained BLS providers to administer IM or IN naloxone with a Class 2 recommendation. So this is sort of a not quite definite recommendation, but something that probably has more benefit than harm. And we'll talk about this second point as well a bit further on in the talk, but naloxone may be considered after initiation of CPR if there's a very high suspicion for opioid overdose. The recommendation is a bit weaker for this particular recommendation, and the kind of sub-point to that is that good quality CPR is a must before you consider administration of naloxone for those who have arrested. So, quick question, with respect to delivery of high-quality CPR, what's the recommended target rate?
Okay, let me just bring that up. There we go. So we'll just give that a few seconds.
We're just calculating to see who's voting here. We'll hold it open for 5 more seconds here. We have 73% voted. Good. Okay.
All right.
Okay, so 52% said at least 100 compressions per minute. 44% went with the 100 to 120. 4% for greater than 120, and nobody for 80 to 100.
All right.
So do you want to give out the correct answer there for?
Sure. Yeah. So 100 to 120 is the recommended target rate as per the AHA currently. It's a bit of a change from 2010, and the reason there's a change is that there's some evidence to suggest that at rates above 120, there's a reduction in the depth and sort of a reduction in other parameters of CPR quality. There's earlier fatigue for providers, and then earlier deterioration of quality of CPR as well. So the AHA is sort of derived from the evidence that's available that at above 120 compressions per minute, there's a bit of a deterioration in other aspects of CPR care, again with respect to depth and recoil. And so they've put an upper limit on the recommendation. In 2010, the recommendation was at least 100, but they've now put an upper limit on the rate, your target rate for CPR. And similarly, in 2010, the recommendation for depth was at least 5 centimeters, and they kind of left the upper limit of that range open. But again, for this iteration of the guidelines, they've suggested that an upper limit be set at 6 centimeters. And again, this has to do with deterioration in other parameters of CPR quality on either end of that range. So 5 to 6 centimeters is your ideal range when delivering CPR.
I was actually speaking with Dr. Fowler, who is one of the Texas medical directors, and he described how they actually arrived at this number. Was they re-looked at the ITD study, which was done with 10,000 different cases, and they looked at, I believe that was the number, and they looked at CPR rates as to what they actually got, and they correlated that, plotted that against mortality, and they found that you started seeing higher rates, like around the 120 area, whereas probably more of an adrenaline-filled, maybe one of our fire colleagues sort of pounding away in the chest, and we actually had a faster and actually improved outcome with those numbers. So then we use those to say, well, maybe the rate should be a little bit faster than what it is. And so it's funny how when you look at just a simple question like that on an existing database, how you can see this plot out. And I don't know, as someone who doesn't really do a lot of CPR, I'm usually sort of somewhere else in the resuscitation room, is the how real world is that application to say 5 centimeters is where to be, but no more than 6 centimeters. It's almost like one of those Monty Python things. It's like 3 is the number of counting, and 4 thou shalt not count, and neither count thou 2, unless they proceed immediately to 3. So I don't know how you can actually measure that exactly, but at least some of the new monitors now have some very impressive technology with that.
They definitely have the push harder to get that depth. But again, I don't know if there's an upper limit where it's going to tell you to not push as hard. So definitely they will tell you to increase the depth. From at least what I've seen at LHSC, but I'm not sure if the technology is out there now to say you're pushing too hard.
So there clearly is a marker for performance, that sort of green zone we're looking to be in. And I've seen some of the colorimetric ones where they actually show the sort of the green diamond, for instance, in the right section when you're in that. But it's really remarkable how this all works. So very interesting. And the whole recoil piece was actually stunning as well.
Yeah. So the recoil. So essentially avoid leading on the chest. When you allow the chest to recoil, you increase the negative intrathoracic pressure, which leads to increased venous return and increased outflow from the heart. But we all know when you give CPR, especially in the older population, their chest wall doesn't really hold up so well. So once you start breaking a few ribs, there's really going to be minimal recoil, regardless of whether or not you're bleeding on the chest or not. So.
Right. There's a study looking at recoil velocity of the chest, and it showed that the better recoil velocity is associated with a higher outcome, a better outcome. Yeah. But to me, the people that have better recoil on the chest are probably someone who's 20, 30 years old versus someone who's 80 years old, where you have one crunch and then it's over, and there's no more recoil. Therefore, but it stands to reason as well that young people have better survivability overall than perhaps the older people do. So it's really important how when you read like the buzz line or the tweet about one study that to recognize that there may be a lot more to it to any study.
Yeah, I mean, definitely on social media, this could come out and say, we need more more recoil on the chest, but again, it's been proven to show benefit. But again, that benefit may just be it's a younger patient population; they have better recoil.
Yeah, so that tweet could actually be young people live better.
That's right, and which we all know. So it's kind of, you know, be careful of what you're reading out there. You have to sometimes dig a bit deeper into the literature to see what the actual message is.
We'll touch on recoil again a bit later with some of the other technology that's available for CPR. And again, just a bit of a summary slide here. So your rate, again, 100 to 120 compressions per minute, depth 5 to 6 centimeters, with a higher strength of recommendation than the rate, and then a compression to ventilation ratio of 30 to 2. And then with respect to perishock pause, we all know that sort of decreasing the amount of time we're off the chest delivering CPR and decreasing the perishock pause is beneficial. So the recommendation formally is that the pre and post-shock pauses should be as short as possible. There's another paper from Cheskis who looked at perishock pause and survival, and essentially broke the patients up into two groups. One group had a perishock pause that was, or sorry, a pre-shock pause that was greater than 20 seconds and a perishock pause greater than 40 seconds, and showed that those patients had much worse survival than those who had pre-shock pauses less than 10 seconds and perishock pauses less than 20 seconds. Locally, I think we do a little bit better than 40 seconds off the chest before and after shocks, which is good. But again, just minimize the interruptions in CPR to maintain your perfusion to your brain and heart.
And it speaks to really having a system, and our paramedic systems are really good at this in the Southwest, about monitoring your time on chest, your CPR fraction. And we know who's really bad at it is us as emergency physicians.
Yeah.
When we're in our own hospital, we just don't measure that and monitor that. And we know that as one of your research studies is we're trying to challenge our own ED partners to actually be good at this, because right now the paramedics are putting us to shame in terms of their CPR fraction.
Yes. Yeah. This has to do again with ventilations with an advanced airway. So this is a bit of a new recommendation compared to 2010, and the recommendation from this year is that it may be reasonable for the provider to deliver 1 breath every 6 seconds, so 10 breaths a minute essentially, when there is an advanced airway in place. This is in contrast to the 2010 recommendation, which delivered a range of ventilation parameters. So in an effort to simplify it, the AHA has just said 10 breaths per minute when you have an advanced airway. And so we'll talk briefly on alternative techniques and devices for CPR. And the first one we'll talk about is an impedance threshold device. This is a pressure-sensitive valve attached to your airway device, and it limits air entry during the decompression phase, so when there is chest recoil, and it increases then the negative intrathoracic pressure, which increases venous return. The recommendation essentially from the AHA is that the routine use of an impedance threshold device is not recommended, with essentially a class 2 recommendation suggesting that there is no benefit.
And so much is the wording, though, isn't it? Because it's the routine use of it because there may be situations like you're just about to discuss here where maybe there should be. So it's so important. Every word by the AHA, and so I find every time we look at them, is so carefully chosen.
Yeah, yeah. And there's definitely you'll notice definitely a preponderance of class 2 recommendations, and those are sort of the vaguely worded ones where it may be reasonable, or you may consider or can consider the therapy or the recommendation, as opposed to the class 1 recommendations where there's much stronger bias towards doing the therapy or completing the recommendation.
Basically, you look at a class 2 as almost, we just don't know. We don't have that answer yet. It's definitely not doing harm. It's definitely not increasing survival. It could go either way. So kind of the class 2 is situational sometimes for some of the recommendations, and that's why they have that very vague wording. It's not as strong.
We have a question online from, does an advanced airway for this purpose of this last recommendation include the King LT or just an endotracheal tube for asynchronous ventilations?
Yes. Yeah, so King LT would qualify as an advanced airway for delivery of asynchronous ventilations.
Which is one of the advantages for us in that we don't have to pause the perishock pause. So by inserting a King LT, it allows you then to continue on with asynchronous ventilations and not having to pause.
Yeah.
Great. Yeah. Thanks for the question.
Another sort of device that can be used during CPR would be, I guess, essentially a suction cup on the chest to decompress the chest during the recoil. So sort of more of an active compression and decompression form of CPR. I think in the past they've used almost just like plungers and put those on the chest and then push down and pull up on the plunger. And again, the rationale is that by increasing the negative intrathoracic pressure, you increase venous return and subsequent cardiac output. And there's been some suggestion, at least with the combination of the impedance threshold device, so again that pressure valve on the airway, that there may be situations in which the combination of those two things has led to better outcomes compared to just CPR alone. I don't know if you want to touch further on that.
Sure. I mean, I remember, I think, Matt, you and I were both in the audience when this trial was published in the Lancet of it was presented, and I think that both of us, or at least myself, one of those, we talk about the bias you have when you hear a presentation. You think, my goodness, why aren't we all doing this? And you dig a bit deeper into it, and there were some elements that were somewhat missing. I believe that CPR telemetry was not measured, or performance of CPR wasn't measured in this study, and also there was some small glitches with regard to some of the authors may have been associated with some of the companies involved, which doesn't necessarily mean it's a bad thing. It just means that questions some of the findings. I think with this large study, you want to be able to see if you can replicate it. If it can truly be replicated in a consistent fashion, well, that's how you change a system. But I remember being blown away when I saw this, and then you wait for, in this era now of social media, you wait for your other colleagues to weigh in on it and see what else people have to say, and it's astonishing what you find. And so, yet again, the lesson for us all is when you see sensational headlines is to not be necessarily the first adopter and wait for some of some replication studies to see how that moves. There's another question here online is when you talk about ACD, does that mean devices like the autopulse? And we're talking about active compression, decompression, is that we're talking about an ACD? The autopulse, for instance, is the low distributing band mechanical CPR, which we're going to get to here in a minute. The autopulse specifically does not have a active decompression piece because it does not have the actual suction cup. So although you have the low distributing band performing circumferential CPR, it doesn't have an active decompression component to it.
Mm-hmm. Yeah, it depends on the natural recoil of the chest itself.
Mm-hmm. Yeah, and yeah, we'll get to the autopulse with the low distributing band in just a couple of slides here. Touch first on the Lucas, which is a sort of mechanical piston that provides CPR. And the recommendation for both the Lucas and the low distributing band are essentially the same in that manual CPR remains the standard of care. However, in certain situations, again, where it might be easy to initiate and set up either mechanical device, where delivery of manual CPR might be difficult or prolonged, like if there's you're just not able to reach the patient to give them CPR, they're hypothermic, you're in a moving ambulance, then outside of these situations, manual CPR is going to be sort of the standard of care for patients. And that sort of has to do with, it takes a while to set up the Lucas or the low distributing band. It takes a big space, and it's associated with a bit more interruption in CPR than straightforward manual CPR.
Yeah, every time we talk about mechanical CPR, I find myself, I get some phone calls afterwards from our industry partners talking about how we are negative towards their particular device. So I want to be absolutely clear about, we talked about during these recommendations, the wording is absolutely essential and is very carefully chosen. So high performance manual CPR may remain the standard, but we all know, specifically best know than anyone as our paramedics, is that it's difficult to perform high performance manual CPR in the environment that they work, which is an austere environment, in ditches, or trying to move people across fields, or moving people, as it actually is even written in the actual guideline, in a moving ambulance, for instance, with limited number of rescuers, where you can't always be changing them. So because of that, since we can't always provide high performance manual CPR, it's very reasonable in that situation to consider the use of a mechanical device, be it the low distributing band or be it the Lucas, the mechanical piston type device. to be able to provide that and bridge that gap. And that's why you see the recommendations written as it is. We still think that high performance manual may be best, but since you can't always get high performance manual, this may be a great alternative for high performance manual.
Mm-hmm. And essentially, the low distributing band is just a different mechanical device, again, where it has a constricting band that goes around the chest wall, essentially, causing compression. And then again, you're kind of dependent on the patient's natural recoil of the chest for the decompression phase. But again, the recommendation is essentially the same as the Lucas, in that manual CPR is the sort of bread and butter, except in certain situations where you can't deliver effective or high-quality manual CPR, and then you might want to consider one of these mechanical devices as an alternative.
What you didn't write here as well as one of the other considerations is paramedic safety, which is super important. Yeah. And those of us that know our group here, we've been very concerned about any kind of alarms that we see with ambulance crashes and the harm that comes with Code 4 transport. And when you think about how important it is to be restrained, and then you think that an option like this allows you to be restrained, well, it's very reasonable to be able to provide asynchronous ventilations through your advanced airway while this machine provides compressions in a safe way while you can remain restrained in the back of the truck. So another sort of component that doesn't really get talked about by the guideline, but I think it's a very reasonable consideration. Balancing some of the cost implications of these devices.
I think that's one of the best features of it is for that safety aspect of it, and definitely, of all the features, sure, it hasn't been shown you throw this device on every patient who is in cardiac arrest because they'll have better benefit than CPR. Well, no, that's not what the literature has showed, but again, maybe looking more at the safety aspect of it, and in the as Mike says, in the back of a moving ambulance where you're holding on trying to do compressions, you may be the only one in the back. This is potentially a place where this may have this safety benefit.
Yeah, exactly. And that sort of fits into where you decide to use the devices or deploy the devices. Sometimes maybe you're seeing characteristics, and this is where we as the basic hospital just don't get involved. This is where our operational experts sort of come in and say, but potentially in these things we're going to do high performance manual on scene or in the field, but once we get them in the truck and we're now driving 40 minutes from a rural place to a local center, we're going to use our mechanical devices. And that may be a reasonable deployment strategy for those models. And so lots of different options out there to be able to accomplish this. And this is why having discussions like this where we focus on the actual wording of the directive is super important, because it avoids us being confused in terms of making broad, sweeping, generalized comments. It's great.
Moving on to advanced cardiovascular care. The first recommendation that we're going to talk about is oxygen. So when you have supplemental oxygen available, it's reasonable to use the maximal inspired concentration during CPR. We'll get into some of the nuances with oxygenation and oxygen delivery a little bit later, but during CPR, certainly just crank the oxygen up as high as possible, and don't worry about some of the sort of negative side effects or consequences from increased oxygen delivery. Certainly you want to maximize the arterial oxygen content during CPR because flow, essentially cardiac output, is a bit impaired during CPR. So you want to optimize the other parameters that you can to improve perfusion to the brain and the heart.
It's kind of unlikely that in CPR you're going to get significant hyperoxia.
Right.
Yeah. Great if you did.
Yeah. And then again, talking about airways, the recommendation from the HA is that either a bag mask device or an advanced airway can be used for oxygenation and ventilation in both the pre-hospital and in-hospital environments. And for sort of the advanced care providers, either a supraglottic device or endotracheal tube may be used as the initial advanced airway. And again, this is from evidence that suggests that during CPR, really there's, if anything, increased mortality in the group that gets intubated, essentially, and whether or not that's because there's interruption in CPR to perform that intervention, or because the patient is sicker at baseline and that's why the endotracheal tube is placed and that's released their mortality, it's a little bit unclear, but certainly either bagging someone or putting in an advanced airway is reasonable during CPR.
I found fascinating about this particular recommendation is for years, like for the last since ALS first began. I remember when Opals was in '97. I know that ages me, but we've always had this we're looking for the answer. We're looking for the black and white answer. Is it the SGA? Is it the BVM? Is it the ETT? What is the answer? And clearly you can see in the latest guideline iteration that all of these, it's very arbitrary, almost not arbitrary, but it's like they're all 2B level of C. It's like, what do you think? Well, you know, you can consider all of them, and the answer is kind of like, yeah, yeah, BVM, good, SGG, yeah, good stuff. Yeah. So it's fascinating.
And this, I should mention, that this is with respect to adult cardiac arrest, where the incidence of, I guess, a hypoxic arrest is going to be much less likely than in a pediatric population. So in adults, when you're not as concerned about hypoxic cause for the arrest, then certainly any form of in-ventilation, invasive or otherwise, is reasonable.
Great point.
Determination of tube placement. So the recommendation from the HA is that continuous waveform capnography is the most reliable method. Certainly might have a equipment limitation to that. But if it's not available, then a non-waveform CO2 detector or an esophageal detector device or ultrasound by trained practitioners may be reasonable alternatives. And that's just, again, to make sure you don't have an esophageal intubation and are insufflating the stomach instead of the lungs. So next question. If you were to administer an antiarrhythmic to a patient with either VF or VT, what would your first choice be?
About 61% that have voted, so we'll give it another 5 seconds here and so we can nudge that number up and then we'll close. Okay. So the results are 25% lidocaine, 67% amiodarone, 0% for magnesium, or 8% for none of the above.
Okay. Yeah, so it's got almost a bit of an unfair question, but essentially the short answer is amio. And we'll look at some of the evidence that they've used to come up with that recommendation. So as for some of the background, some antiarrhythmics have been associated with increased rates of ROSC and hospital admission, but none in and of themselves have been shown to increase long-term survival or survival with a good neurologic outcome. Essentially, the AHA statement is that the optimal sequence of ACLS interventions, including antiarrhythmics, is not yet known. Looking at amio itself, amio for VF or VT has not been shown to improve survival to discharge or survival with favorable neurologic outcome compared to placebo or compared to lidocaine. Although studies that they've used in this sort of recommendation have not been powered to look at survival differences.
Do you mind just explaining, maybe someone who's not as familiar with statistics, what does that mean, not powered to detect something?
Sure. So when you're designing a study, it's the best way to explain is that you need, if you're looking for a difference, or an outcome difference, you have to kind of determine how frequently that outcome occurs, first and foremost, and then you kind of have to decide at what sort of level of power you're going to accept to look for that difference in outcome. And in doing so, you need to figure out how many patients you would need to either have the outcome or not have the outcome to look for whether or not that's a significant. That's probably a terrible way of explaining it. But.
Yeah, I mean, you're right there. The biggest thing is how often does this event occur? And you're going to need so many events to occur within your study in order to say there is a significant difference between the two groups. And a lot of these studies, in order to detect that difference, as Mike said earlier in the presentation, these events are very far and few between, that you need thousands and thousands and thousands of patients enrolled in these studies, and that's when it becomes, you know, these consortiums, these big research studies. That's why you have groups collaborating, because you need such large numbers. So oftentimes, you know, sometimes studies come out and they just don't have enough people enrolled in that study to have the event occurring to say that there is a difference. And that's when you hear words about, you know, trending towards significant, but you can't say significant because it wasn't powered to detect that significance.
I think the best example of that, which maybe perhaps the paramedics can relate to as well, is outside of cardiac arrest is the cervical spine fractures. So we know the prevalence of cervical spine fractures is very low amongst all the people we board and collar. So therefore, as you can see from Christian Weinkor's work out of Ottawa, I was trying to be able to frame the decision rule for paramedics as to who we need to put collars on versus not. You need a certain number of cervical spine injuries to actually happen, so you actually know, well, because you could randomize everyone to absolutely no immobilization whatsoever, and you'd only have one spinal cord injury or two spinal cord injuries per year, but that may be the baseline rate of spinal cord injuries that happen, period. So you could randomize, in theory, someone to like a very cool, funky scarf that they wear as their now immobilization device and show that it's equal to cervical spine collar immobilization, but that is based on if there's only one cervical spine fracture, it works out the same. So you got to be really careful as to how to drive these studies, and that's why you see, like Matt mentioned, ROC happen, is that you have these consortium, these huge groups that develops huge numbers, and that's what it becomes intimidating about research. But you can sometimes answer, as we've done here, small questions locally, right? So that's what makes it fun about research. Can't believe I said that in a sentence.
And similarly, with lidocaine, lidocaine did not increase rates of ROSC or survival to discharge in some observational studies. And in at least one prospective randomized control trial, it's been shown to be less effective than amiodarone in improving hospital admission rates after out-of-hospital cardiac arrest. Talk briefly on the ALPS, or the amiodarone lidocaine versus placebo study. This study randomized over 3,000 patients with persistent or recurring VF or VT after at least one shock, and they gave them either amiodarone, potentially up to 450 milligrams, or lidocaine up to 180 milligrams, or placebo, and then looked at outcomes including ROSC and survival to discharge. And overall, there was a trend, again, so not necessarily a significant finding, but a trend towards improved survival with amiodarone and lidocaine compared to placebo. For EMS witnessed arrests in particular, the benefit was much in favor of amiodarone versus lidocaine, and for bystander witness arrest, there was sort of benefit to both amiodarone and lidocaine, and no benefit to either of those with non-witness arrests. So it seems that most of the evidence, most literature is in favor of amiodarone, at least as an initial antiarrhythmic for VF and VT.
And the earlier we get it, the better.
Yes. Yeah.
But the recommendation still is there's no recommendation hardcore for a sequence of things on a cardiac arrest because of other competing priorities. So it's remarkable.
And essentially, magnesium has no role in as an antiarrhythmic for VF or VT. And so again, just to hammer that point home, amiodarone may be considered for VF or pulseless VT that's unresponsive to CPR, defibrillation, and vasopressor therapy. Lidocaine may be considered as an alternative. However, amio is probably the better first choice here. And again, no routine use of magnesium is not recommended. And so moving on to sort of other drugs used in cardiac arrest care, we'll talk about vasopressors. With respect to epinephrine, the recommendation is that standard dose epi, so a milligram every 3 to 5 minutes, IV or IO, may be reasonable for patients in cardiac arrest. There's really no benefit, though, with epi and survival to discharge or survival with good neurologic outcomes, but it does increase rates of hospital admission, and that's why it's used in ACLS or cardiac arrest care. Vasopressin, previously on the algorithm until this iteration of guidelines came out, essentially the evidence suggests that vasopressin has no benefit in out-of-hospital cardiac arrest, so it's not used anymore on the algorithm. So just epi. And with respect to steroids, again, the recommendation for patients with out-of-hospital cardiac arrest, the use of steroids during CPR is of uncertain benefit, with a Class 2B recommendation. There is some evidence, at least in the in-hospital environment, that there may be improved rates of ROSC with the addition of steroids, but that really hasn't been extrapolated to the pre-hospital environment so far anyways. And again, we've talked about this briefly earlier, termination of arrest with end tidal. And again, with end tidal, less than 10 immediately after intubation or less than 10 after 20 minutes after CPR has been started has been shown to be sort of a poor prognostic factor. Again, not to be used in isolation when determining when to cease resuscitative efforts, but to use as a piece in the puzzle for determining prognosis. And now post-arrest care. So the recommendation from the AHA is that angiography should be performed emergently rather than sort of on a semi-urgent basis for out-of-hospital arrest patients with suspected cardiac etiology and ST elevation as a level 1 recommendation. As well, they recommend angiography for suspected cardiac arrest patients from a cardiac etiology that don't have ST elevations. Is this going to change how you do things? I'm not entirely sure. Like if someone has a STEMI on ECG, obviously you're going to go the code STEMI route, at least here in the Southwest. And if someone doesn't, then it's certainly reasonable for them to go to the cath lab from the emergency department. Just I guess an important thing to keep in mind from the AHA, and that kind of we'll talk a bit later, but it sort of signifies the importance of recognizing STEMIs on ECGs and then initiating the sort of direct communication with the cath lab to improve their outcomes.
This is where I see our specialized cardiac centers coming into a tackle, is that there's certainly recommendations from cardiology groups as to who they take to the cath lab in the middle of the night post-ROSC.
Yeah.
And there was some recommendations initially in 2010 that spoke to, regardless of your level of consciousness, regardless of your cardiogram, you still went to the cath lab. And then we found the likelihood of finding a culprit lesion angiographically was less. So they refined these a bit for this iteration to talk about definitely if you have a STEMI for sure, as you mentioned, but if you're really unstable despite the STEMI post-arrest, let's take you. Yeah. But now, who knows really what to do? Well, you probably need timely angiography at some point, but doesn't necessarily mean to be 3 o'clock in the morning. And so this is why I think we, as a paramedic system, we need to allow them the opportunity. And I know Matt and I have a meeting in the central region here with our interventional colleagues about trying to define what that looks like for specialized cardiac centers later on next week, actually. So we'll see this affect our paramedics at some level, and this is the science that goes behind it.
So you resuscitate a patient who was in VF and now has a pulse but is unresponsive. Do you cool this patient in the pre-hospital setting?
Pulls open. Good. So we got about 70% voted there, so we'll pull that poll down now. And we have 33% said yes, we cool them, and 67% said no, we don't cool them.
Yeah. Okay. So the answer to this question is no in the pre-hospital environment, and we'll look a bit into that in a few slides here. So this has to do with targeted temperature management, and with in-hospital arrests, the recommendation is that adult patients with ROSC may benefit from targeted temperature management in the in-hospital environment. And this is for the target temperature is between 32 and 36 degrees. And this sort of leads to better neurologic outcome, more favorable neurologic outcome, and better overall survival. However, in the pre-hospital environment, the AHA recommends against the routine use of pre-hospital cooling after ROSC. Essentially, the way in the past, like the way these studies have been designed is that in patients who have ROSC post-arrest, they've been cooled with cold IV fluids to try and get to a target temperature of 32 to 36. And the rationale is that if this intervention is good in the in-hospital environment, why wouldn't earlier administration of this therapy be better? And essentially, the evidence suggests that there's no difference in outcomes with respect to neurologic recovery or survival when cooling has been started in the pre-hospital environment. And in fact, there's some evidence to suggest that there's higher rates of pulmonary edema and rearrest with rapid administration of cool IV fluids in the pre-hospital environment. So based on that evidence, the AHA recommends withholding this therapy to people who arrest in hospital environments.
My worry with this has always been when you have run a cardiac arrest in the pre-hospital environment, you get a return of spontaneous circulation. Oftentimes it's a bradycardic ventricular escape rhythm. And I never knew if it was safe for us to all of a sudden smack that person with ice, bolus in some cold saline. You get this tremendous vagal surge, and then all of a sudden that potentially could give you a rearrest. And it's interesting to see that we're starting to see, I don't know if that's the mechanism, but we are seeing that there is a higher incidence of rearrest in these patients that are cooled pre-hospital. And maybe the theory is that if you're, by the time your inflammatory cascade kicks in post-arrest, post-ROSC, to get you that hyperthermic response, maybe 6 or 8 hours down the road, whereupon starting fluids or cooling them pre-hospital in that very unstable 5-10 minutes immediately post-rest versus 30 minutes, 40 minutes when they have a more stable rhythm, then you may not change your target temperature moment, and then it still allows you to maintain targeted temperature management below 36, and that may be why we're not seeing the actual impact we used to think we would get from the pre-hospital cooling. So really important point. And the example, because remember 4 years ago, this is a huge thing. Why are we cooling these patients? Well, you can see how the systems now change, and the pendulum, it can be quickly moved, but all of a sudden you stay the course and you wind up being a little bit vindicated by that sometimes.
And that can be a pitfall or a danger around research is you find a positive finding in one setting and then you want to extrapolate that to another setting. Well, that's not where the research actually took place. So there's various factors that aren't taken into account, the pre-hospital versus emergency department setting, the emergency department versus the ICU setting. And so there's always this move towards, well, why aren't we doing it in the pre-hospital setting? Why are we doing the pre-hospital setting? And again, these studies haven't taken into account these other factors that may be occurring, which may cause more detriment than benefit, and kind of played out with the pre-hospital hypo or cooling in terms of the cardiac arrest patients.
What's fascinating about that, we just said, Matt, is you're absolutely right. It's very clear now the science is showing us what our paramedics have been telling us all along. The pre-hospital environment is very different than the ED environment, which is different than the ICU environment. So no one knows that the environment of the pre-hospital environment where our paramedics are experts is different than the ED. It absolutely is, and you're seeing that here. Great.
So ROSC and oxygen. So we talked earlier about how during CPR, basically administer the highest concentration of oxygen available to you. However, after ROSC is obtained, it's reasonable to decrease the percent oxygen administered, provided they're not hypoxic, so provided the patient has a SAT above 94. And this is to reduce consequences associated with hyperoxia. Patients who have had an infarct, who then get 100% oxygen, have been shown to have larger infarct sizes and worse outcomes when they're administered 100% oxygen versus just preventing hypoxia. And that's something that certainly can be done in the pre-hospital environment. And then, again, one of the later parts of the AHA guidelines has to do with acute coronary syndromes. With respect to the pre-hospital ECG, the recommendation is that the ECG should be required early with patients with possible ACS. Seems like a straightforward recommendation there. And pre-hospital notification of the receiving hospital, again with a specialized cardiac care center, should occur for all patients with a STEMI on ECG. And that's so that they get earlier access to angiography, earlier intervention of that sort of culprit lesion causing that STEMI, which has been shown to improve survival and neurologic outcome.
And just to kind of bring the guidelines back home, some of the paramedics within our region actually contributed to some of this research that went into the guidelines, looking at the pre-hospital ECG and the actual changes that do occur on the pre-hospital ECG that do impact management. So, the research is occurring here in the Southwest, which is actually impacting international guidelines. So you're part of that, and we thank you for that.
ECG interpretation. essentially relying solely on the computer to interpret the ECG is fraught with difficulty. So there's high false negative rates, high false positive rates, and so the computer interpretation alone should not be used to diagnose STEMI. Rather, the computer interpretation should be balanced with either physician or trained provider in recognition of STEMI.
Yeah, so again, the machines are more likely to call something a STEMI that is not a STEMI as opposed to the opposite. It very rarely will miss a STEMI, but often overcalls it. And that's where the emphasis is on a trained provider, being paramedics or physicians as well, to, once the ECG does say, yes, this is an MI occurring, then the trained provider is going to look at that ECG and determine, yeah, this is an actual STEMI versus no, it's overcalling it. This is actually a left bundle branch block, and it's thinking that it's a STEMI.
And this sort of has to do with the same concept of transmission of the pre-hospital ECG to the emerged physician may improve the positive predictive value and therapeutic decision making regarding STEMI. However, when transmission is not performed, it's certainly reasonable for the trained non-physician ECG interpretation to be used as the basis for the decision to activate the cath lab or not. And then it goes further to also include that interpretation can be used to make the decision on whether or not fibrinolytics should be administered and destination hospital choice. STEMI and AEP. So the recommendation from the AHA in patients with suspected STEMI intended to undergo PCI, initiation of ADP inhibition may be reasonable in either the pre-hospital or hospital setting. So this would be things like Plavix or ticagrelor would fall within the category of ADP inhibitors. This, from the emerge anyways, this happens sort of in conjunction with the interventionalist or with the cath lab, and whether or not that's going to be implemented in the pre-hospital environment, not entirely sure. I think the most important thing to keep in mind is that recognition of STEMI and activation of the cath lab based on the ECG is probably the most important thing here.
And again, a perfect example of, the evidence just isn't there for the pre-hospital setting. So sure, it seems like a good idea that these patients are given the medication similar to aspirin earlier the earlier the better. The evidence just isn't there. And again, the trap being that, it's implemented without the evidence, and then we start seeing negative consequences. So, down the road, potentially, we don't know that the evidence just isn't there.
Similar to the ADP inhibition, EMS systems that do not currently administer heparin to STEMI patients should not add that in their scope of practice when treating STEMIs, whereas those that do currently administer it may continue their current practice. And again, this kind of speaks to the sort of, not necessarily ambiguity, but sort of the
we just don't know which practice is better. So at this point, both practices are deemed acceptable. Yeah. And yet the evidence, down the road, 5 years from now, 10 years, it may be that one is acceptable versus the other, or we may never have the answer.
Mm-hmm. Yeah, and that's why these guidelines it's sort of an iterative process or dynamic process. And as more evidence becomes available, then the guidelines get refined and updated. Similarly, again, may be reasonable to consider the pre-hospital administration of unfractionated heparin in STEMI patients, or the pre-hospital administration of bivalirudin in STEMI patients who are at risk of bleeding. But again, this is something that I think is yet to be sort of drawn out, and we'll kind of have to wait and see which direction this goes for the pre-hospital environment. And again, STEMI and oxygen, so kind of alluded to this earlier, in patients who have had STEMIs, rather than providing oxygen, the maximal rate of oxygen, I think the important thing to keep in mind is that you want to prevent hypoxia. And again, that is because hyperoxia is associated with larger infarct size and worse outcomes. Similarly, hypoxia is bad for patients with STEMI, and so you want to find that kind of happy medium where you're not necessarily over-oxygenating their arterial blood, but you're preventing hypoxia at the same time. And pre-hospital lysis, again, this is probably something that is going to take a bit of time to draw out and make conclusions from, but where pre-hospital fibrinolysis is available as part of a STEMI system of care, so in systems that already use pre-hospital fibrinolysis, it may be reasonable to administer pre-hospital fibrinolysis when transport times are prolonged. Again, from the emerge anyways, locally, this is done sort of in conjunction with the interventionalist, and so I think we still kind of have probably years to see where this goes in the pre-hospital environment. All right, so just a couple slides left here. I think this is the last question. You receive a call about a patient with a suspected opioid overdose. When you arrive at the scene, the patient has no pulse. What is your next course of action?
Actually, I don't have this
Okay.
one loaded up. Sorry.
Oh, that's okay. With that question in mind, the options are A, administer IM naloxone, B, use standard ACLS guidelines, C, support and assist the patient's agonal breathing, and D, call for a TOR. The answer is B, use standard ACLS guidelines. So we talked briefly earlier about naloxone and how it's appropriate to use by trained providers in patients who are unresponsive but have a pulse, unresponsive with either agonal breathing or abnormal breathing. These patients certainly, when they receive naloxone, should have access to advanced healthcare services because the naloxone will wear off. However, in patients with no detectable pulse, even with a strong concern for opioid overdose, standard ACLS, standard resuscitative efforts should take priority over naloxone administration. And again, we talked about one of the recommendations earlier in the talk where naloxone may be considered only after sort of good quality CPR is being undertaken, and that's because the naloxone is just not going to be delivered systemically without CPR, and the naloxone is not going to be beneficial as a therapy for the arrest itself, and that's why CPR is so important here.
Yeah, I mean, most of the causes, the reason why these patients are in cardiac arrest is because of a hypoxic or a respiratory arrest. So again, the natural evolution of that is to restore the oxygen, restore their ventilation, and doing the CPR. So focusing on those aspects of care. When it comes to the potential use, so you come into an area and there's needles lying around, you've got a witness saying that this patient has overdose. Again, focus on your standard cardiac arrest algorithm, and then at that point, if there is a concern for potentially opioid overdose, potentially a patch to the base hospital physician to make a joint decision regarding the use of Narcan in these patients. Again, it's going to be a rare occurrence, and we don't want everyone, who is down with no history, let's give them some Narcan just to see if that works. Again, this is going to be a highly suspicious cardiac arrest. Again, focus on the BLS and ACLS aspects of care, and then at that point, make that patch and make a decision with the physician.
So lastly, just a quick summary slide. So again, guidelines are historically renewed every 5 years. However, this may be changed for the future as evidence becomes available. The AHA may be more dynamic in their release of information. And then important points. So dispatch should be able to recognize cardiac arrest in a multitude of scenarios and be able to provide instruction for bystander CPR. There's no clear role for naloxone in cardiac arrest. However, it is appropriate in patients who have a suspected opioid overdose with a pulse and abnormal respirations. Targets for CPR include a rate of 100 to 120, 5 to 6 centimeters of depth, and allow for full recoil, and no more vasopressin on the algorithm.
So thanks, Drew, for that presentation there. It's a huge topic, hard to get through in that, and there's a lot that we did not cover with this webinar, but tried to pick out kind of the more relevant pre-hospital aspects and the bigger changes that have occurred with the 2015 guidelines. So if there's any questions, by all means, feel free to send them in, and any other questions that you can't get sent in, you can always contact one of the pre-hospital care specialists with the questions, and they can help answer it or pass it along, and we can definitely answer it offline.
Okay, so we'll just stay on a little bit longer, maybe another 30 seconds, 1 minute, to see if there are any questions. Okay. So we do have a question that has come up.
And the question is a false negative on the monitor, is the false negative of the monitor on STEMI, not saying it's not a STEMI when it is. So a false negative, so you have your true positives and your true negative. So true positive is, yes, that's a STEMI, and it actually is a STEMI, so it calls it correctly. A true negative is it does not call it a STEMI, and it is not a STEMI. So what the machines are designed, and I hope this answers your question, the machines are more likely to overcall things. So they will most likely have a false positive as opposed to a false
negative. Yeah.
False negative. So a false negative would be a STEMI is occurring, the computer doesn't recognize it, and the patient is actually having a STEMI. So they are designed to overcall, not undercall.
So yeah, you'll more likely encounter false positives where the computer algorithm reads out STEMI, but the patient is not having a STEMI. That slide, you're right, that slide did say false negative. Sorry about that.
Sorry for the confusion there. And we got another question coming in. Is a pre-hospital rate of CPR for two-person CPR 15 to 2 for children, or do you prefer keeping the rate at 30 to 2? So in terms of what the CPR fraction should be, there's been no changes in the 2015 guidelines in terms of single rescular versus two rescular CPR ventilation ratios, or in terms of the only change that's come down is with the advanced airway, just keeping it at 10 breaths per minute. So there's been no changes in terms of what the CPR ratio to ventilation should be in pediatrics or adults.
Okay, so it looks like we have no more questions, so I think we'll stop right there. Thank you for joining us this afternoon, and thank you to our presenters as well. And you have yourselves a great afternoon.